Hi, I'm Paula, and I'm the physical therapist.
Hi, I'm Ariel, and I'm the patient.
Hi, my name is Debbie, and I'm a dietitian.
Hi, I'm Natasha, and I'm a nurse.
Hi, I'm Dr. Dre, and I'm the doctor.
Hi, my name is Sally, and I'm a social worker.
Hi, Ariel. I'm Dr. Dre. I understand you're getting a prosthetic arm fitted today. Do you have any questions for me?
Yes, I was wondering if these things even work.
Yes, they do. We've actually come a long way since the first ever prosthetic limb, which is actually dated back into the Egyptian times. The first ever recorded prosthetic limb was a toe. It was actually used for more of a burial process. They wanted to make sure that anybody who was missing a limb would actually be buried with a limb. So they used a toe back then. And then if you see in Italy in 424 BC, they used the artificial leg of bronze and iron. It did the purpose. It wasn't very structurally sound. But then we go to the mid-1500s, a barber, he's also a surgeon, he found the first above-the-knee device with adjustable properties. And then if you come today, we actually have a lot of prosthetics that are very helpful, and there's actually one out today that has sensories that goes up to your skin, and then it actually can tell you if there's any heat or cold. So we've come a long way since then.
So what are they made out of?
First, I would decide the type of prosthetic I would use. We would figure this out during arthroplasty. I have several options we can choose from. We can do a metal, ceramic, porous-coated, cemented, or non-cemented. Prosthetics can be affixed in several ways. We use a bone cement that is like a putty-like substance, and we use this to pack into the bone that would harden into place and put the prosthetic rooted into place. A porous-coated prosthesis can be used in the hopes a healing response will occur to allow the body to develop its own bone and adhering the prosthetic into place. We would use a coating, which is a bioactive ceramic substance that allows the body to generate new bone growth and to hold the prosthetic into place. In fit stabilization, the prosthesis is the same size or smaller than the surface being replaced. I would use a hammer to hammer the components into place, allowing the prosthesis to stay into place. Knowing and understanding the types of prosthesis and fixative is important for rehabilitation care. So it's up for you and I to decide which would work best for you.
So do I have to worry about any limitations using it? Can I use it like I normally would use my arm, or is it going to fall out? How do I keep it in place?
That's a really good question. The most common cause of painful or increased dysfunction of a joint is due to loosening of the prosthetic. Aseptic loosening is the most common cause of a failed joint replacement. It may appear years later after the initial surgery by wear and tear of the prosthetic devices. Dislocation can happen within the early postoperative phase, but more than half occur within the first 4 to 6 weeks of surgery.
So if it were to happen, how would I even know, and when would I determine if I should come in to see my doctor?
Well, patients often complain of an immediate pain and it has like a sound of a pop. So if it did, we would need to go in and get an x-ray to confirm any dislocation.
So do I have to worry about an infection?
Infections happen in less than 2% of all prosthetic cases, so although it can be an issue, it's very rare that it would happen.
So is there anything else I should worry about?
Well, there is a major concern after surgery. It could be a potentially life-threatening complication, that is a deep vein thrombosis that could turn into a pulmonary embolism. Patients who have had a joint replacement may need all triad criteria, which would do a loss of vessel wall damage, hypercoagulability, and venous stasis after surgery. So what we would do after we take care of you is we get some Coumadin, low molecular weight heparin, or we could do unfractioned heparin. It is common to administer anticoagulants immediately post-operatively up to 14 days after.
Did you know today the most common cause of lower limb amputation is smoking, which accelerates hardening of the arteries and often results of the loss of both legs?
Hi, my name is Debbie, and I'm a dietitian. My role on the healthcare team is to instruct the client and the family in proper dieting. Post-operatively, the patient will be on a clear liquid diet. This is after anesthesia to allow the bowels to wake up. Eventually, they'll progress to a high-protein diet. This will promote healing from the surgery. Eventually, they'll progress back to their regular diet. The most important thing for the patient is to make sure that they're meeting their energy requirements. Now, these energy requirements might be different because of their altered physiology. They'll also likely have a different activity level than they did pre-surgery. So we'll want to make sure that they're getting the nutrients that they need, but also controlling their weight.
Hi, I'm Natasha, and I'm a nurse. My role in the rehab process is to orient the patient in their new rehabilitation program. That includes providing pain management, providing pre-op and post-op education, as well as including the family in all support services and including the family in the education process as well. Some nursing diagnosis to take into consideration. Body image disturbance related to prosthetic arm. In this case, our interventions could include identification and use of helpful coping techniques. We can assist the patient and family in identifying support groups that are available to them and provide support by actively listening. A second nursing diagnosis to consider, alteration in comfort related to phantom or residual limb pain. Our nursing interventions administer the appropriate pain medication as needed. You can encourage the client to report limb sensation and pain and assist the patient to find comfortable positioning and support during movement. The patients often lack the knowledge and the skills that are necessary for maximum individualization. So as stated before, it's very important to involve the family not only in the physical, but the psychological and social changes associated with the new prosthesis. Providing proper education, transfer techniques, and care for prosthetics is very important. This again includes pain management, skin inspection, and use of assistive devices.
Hi, my name's Sally, and I'm a social worker. My job on the healthcare team is to coordinate discharge planning. In that area, I would ensure that the patient has the proper equipment and assistive devices that they need at home. I'd also assist with post-hospital care, coordinating a home health aide or a home health nurse to be at the home with the patient as needed for their rehabilitation. I would also assist with securing entitlements and benefits that are due to the patient, such as Social Security, disability, income, things of that nature.
Did you know, in times of peace, approximately 74% of all amputations are due to disease? Accidents account for another 23%, and the remaining 3% are the result of birth defects. Hi, Ariel.
Hi.
I'm Paula. I'm your PT. I'm going to be working with you today. Your prosthetic looks great. It looks like Dr. Dre's work.
Thank you, it sure is.
Well, before we get started, I'm going to tell you a little bit about what it is that I do. So I do help diagnose and manage any dysfunctional movement. and more or less just do a general eval each time we meet. And we want to assess your mobility, your muscle strength, your range of motion, any pain that you may be experiencing, and any issues with balance. A main concern that we want to keep an eye on is managing any pressure sore areas and any abnormal tissue degeneration. There are ambulatory aids that we can use and care of any residual limb pain or sensation that you may have. And in addition to that, we want to, of course, prevent any contractures or, like I mentioned, any pressure sores. So, as a part of your pre-op assessment, we went ahead and, as you know, did a past medical and surgical history and really wanted to gauge a good idea of what your prior level functioning was. Also, take into consideration both pre-op and post-op any pain you may have, any stressors. We're also going to do some observational and functional assessments, and that'll include just observing you sitting and standing and walking. I also want to make sure you're not having, or if you are having, any residual limb sensation. That would be also known as phantom limb, and that would be if you're experiencing any sensation of where your limb used to be. So, included in that assessment, I'll just do some palpation and some measurements. And since you do have a prosthesis, I also want to observe you both with and without the prosthetic so that we can determine if there's any corrections that need to be made. Also, we'll just kind of take a look and see your muscle in general, muscle testing, and determine your strength. And that'll help us to plan your activity and how to work with your active and passive range of motion, and kind of just help us get a scope of where you're at and help us determine the goals to be met. So finally, before we get started, I want to let you know that through the course of your rehab treatment and my job with you as your PT, I'm going to help you identify just the proper care of your prosthesis and the different devices that we use. One of which is a liner or a shrinker, which is used for limb wrapping. And that's important to reduce your chance of having any edema or swelling. And I also want to help you identify if you start to notice any swelling, because that is a potential issue that we may run into that we want to avoid. So I will also help train you to properly adjust and apply your prosthesis and proper care of the prosthetic in general. And that'll, of course, help to avoid any complications or infections that may occur. I'll also help you identify any signs and symptoms of infection. The proper care is going to include cleaning of the socket, and that'll be done when you remove the prosthesis for a day, or at the end of the day rather, and we'll go through the details of that as well. But generally, when you have your new prosthetic, you're not going to be wearing it full time in the very beginning. So again, we're going to help you identify just your daily inspections. That's going to eliminate any blisters or discolorations, and how to inspect those open areas to avoid any skin breakdown.
Did you know, of all the congenital birth defects requiring a prosthetic, the most common is the absence of the lower left arm? There is no satisfactory explanation for this phenomenon. Meet Cody, a real-life story. On December 4th, 2009, Cody was born with 2 legs, 2 feet, and 10 little toes, but his right leg curled inward and the foot pointed up towards his body. At first, family thought his leg may have been broken in the womb, but x-rays soon revealed he was missing his tibia and knee. The diagnosis was tibia hemimelia, a rare congenital malformation that occurs in approximately 1 of every 1,000,000 live births. An amputation was performed when he was just 8 months old, above where the knee would have been. Cody was placed in a body cast that covered his amputated limb and continued up and around his waist, with a cutout on the bottom to allow for diapering. But that huge cast didn't hold this little guy back. On his first day home from the hospital, he actually learned to crawl. Here are a few pictures of Cody at the start of his journey. This is Cody being fitted for his prosthesis for the first time. And here is Cody giving a high five to Blake Leeper, a Paralympic athlete. Here's a friend of Cody's and the prosthetics that he has outgrown.
Hi, my name is Debbie, dietitian. Wait, that's not my whole name. My name is Debbie, and I'm a dietitian. This is gonna be so hard.
Say Debbie the dietitian.
Okay, we're starting.
Hello, everyone. We have come a long way since the ever prosthetic limb, which actually dated back into the early times in Egyptian. The first prosthetic was actually a toe.